And this has been just a wonderful way of showcasing the interdisciplinary nature that this part of our field has taken with 4 different societies, et cetera. It's worth stating, 5 years ago last week was the very first webinar put on by the Congenital Heart Academy. It was about 2.5 weeks after the lockdown for COVID. And we decided that it was time to, at the time, we were doing a number of fellowship webinars. And it sort of grew when we recognized the need for both interdisciplinary and international sharing of knowledge and best practices. We have somewhere in the range of 32,000 unique visitors to the Congenital Heart Academy. We've had hundreds of webinars that are all available on our website, which you can just look up on, or excuse me, on our YouTube page. You can look them up. And this collaboration is, I think, the most impressive and ambitious to date. And this session today is the most ambitious of the ambitious webinar series that we have. And real kudos to Chetna and Sam for putting this all together. Before I turn this over to Chetna, I just wanted to share one thing and just give a quick shout out to 3 of our organizing committee members, Melissa Jones, Cheryl Caparola, and Sarah Schlatter, who just published this paper, which I'll be putting in the chat. I hope it's helpful to those of you who are starting programs. Melissa in particular has been the glue that has kept this program together for nearly 10 years now, and all the challenges and the way we dealt with them are in this manuscript. So I will put this into the chat, and it's so great to see. Oh, Grace is on too. Grace, I took your job. I'm sorry. I don't know if you have anything
Thank you so
you want
much,
to say.
Gail. I'm so sorry with the change of the US time, and I'm being in Brazil since yesterday. The time slot for me is completely wrong.
Oh,
But
okay.
it's good that I'm here now.
Well, you're not alone. Thanks for joining us. So Sasha, Grace, and I, 5 years ago now, got this thing started. I think if you had told me that we would have this webinar with us on with the experts that I see on the screen right now, I would never have believed it. So Chetna from Texas Children's Hospital is a cardiac intensivist and very interested in improving the long-term neurodevelopmental outcomes for our kids, has been the course organizer here, and I'm going to turn this over to you, Chetna. Thank you.
Thank you. Thank you. So I'm Chetna Pandey. As Gil said, I'm a cardiac intensivist at Texas Children's Hospital in Houston, Texas. So just a few housekeeping things I just kind of want to go over. So let me share my screen. Let me switch my display. Can you guys see that okay, Gil?
Yes.
Great. So just a word about all the groups that have come together. So Gil just introduced the Congenital Heart Academy. So CNOC, the Cardiac Neurodevelopmental Outcome Collaborative, and PCICS, Pediatric Cardiac Intensive Care Society. They are both international groups, multidisciplinary. Anyone can join. We're all really proud of the groups that they just include people from all different types of providers, therapists, nurse, physicians, APPs. And it's just really bringing together like-minded people to work on research and advance our group. And so you can follow us on social media or learn more at the links over there. And then Sam Butler is one of the leaders of the Cardiac Newborn Neuroprotective Network. And this is a special interest group within CNOC that has really been that has helped put this together truly. And so you can follow them on social media as well, and reach out to us if you have any more interest in it. All right. So just as a, So just as a reminder, I know my screen's not sharing. This is number 3 in our webinar series. In April, May, and June, we have the next 3 where, I've spent the first half of the series talking about all the ills of everything we do to these kids. And then the second half of the series, we'll talk about how can we mitigate some of these issues. And then just a quick shout out, we'll be having the first ever CHG multi-center skin-to-skin-a-thon that Shannon and Sarah on our panelists group have been putting together. It's 27 participating hospitals. It's the very first of its kind, congenital heart disease and CICUs and CPCUs. If you're interested in having your institution participate, just go to the QR code and get registered. And then Carly is going to be co-moderating with me. Carly, I'll let you introduce yourself and take over.
Thanks, Chetna. My name is Carly. I'm from Nemours Children's Health in Wilmington, Delaware, and I am thrilled to be here today. The previous two webinars in the series focused on an overview of neural development in CHD, as well as state-of-the-art in advancements in neuroimaging and neuromonitoring. If you missed those series, please catch them on the Congenital Heart Academy YouTube channel. They were fantastic. And before we start speaker introductions, we do have a few housekeeping reminders. Please post your questions in the Q&A section, and there will be panelists that will be answering those questions during the program. But please stay on till the end of the presentations, where we will be providing a live Q&A with the speakers and panelists.
Perfect. All right, so let's finally get started with today. So today's series, the ills of the ICU. So I'm a cardiac intensivist. I obviously love the ICU. It serves a very necessary purpose in, providing a space to keep these children alive, quite frankly. But, it certainly has its ills, if you will. And so today what we're hoping to kind of walk you through is potentially some of the modifiable factors that may potentially have short and long-term effects on the developing neonate's brain. And so with that, I want you to just kind of take a moment to think about the neonate that's born that doesn't go straight to the ICU. So baby is born, stim, warm them up, and then immediately put them to birthing parents' chest, right? We want to keep them on the mom's chest as long as we can. We encourage lots of skin to skin with with any of the caregivers involved. If mom is interested in breastfeeding, we put them to breast as frequently as we can. We obsess over keeping them warm. I know my parents, my son's grandparents were obsessed with putting socks on my son's feet and keeping him warm. When you go home, we're always working on keeping a very quiet, wholesome environment. Don't be too loud. Don't have lights too loud. Let the baby sleep, really focusing on the baby's sleep. We go to pediatric visits fairly frequently in those first few months. We work on milestones. We get vaccines. We check their weight obsessively, or I did at least. So I just want you to keep that in mind of how we treat the neonate when they're born, if they're not going to the ICU, and then just contrast that with everything that we're going to go through today. And so with that, Carly, you want to introduce our first speaker?
Absolutely. Our first speaker in this all-star lineup is Dr. Eric Graham. He is an intensivist and chief of pediatric cardiology at the Medical University of South Carolina, and he will be talking to us about a topic that is quite interesting: plastic exposures in the ICU and its potential impact on the brain. Take it away.
Thank you so much. It's an honor to be here. Let me share my slides real quick. Great. I hope everybody can see that. Let's see here.
Doesn't see your screen, great.
Okay.
Perfect, Eric.
I have no disclosures. Okay, so this is me 20 years ago. Back then, I remember sitting in the audience in my very first PCICS meeting. And back then it was in person. It wasn't one of these wonderful virtual sessions we have now. But I remember listening to Gil, and Gil was discussing neurodevelopment. And he said that infants lose an IQ point for every day in the CICU. That message has stuck with me to this day. Now, over the past 2 decades, we would blame neurobehavioral disabilities on the surgeons, perfusionists and their bypass circuits, anesthesia and their medications. We would blame genetics, the maternal fetal environment, and even the baby for being small, premature, or having complications. Yet over these 2 decades, we have discovered that currently identified risk factors do not adequately explain the incidence, mechanisms, or considerable variability we see. So what if I told you I think we're poisoning these babies? So exposure to industrial chemicals, both in the home and the healthcare environment, are increasingly being recognized as harmful. In the healthcare environment, a newborn exposed to the environmental contaminants in conjunction with the intrinsic risk factors associated with congenital heart disease, such as brain dysmaturity, hypoxia, and exposure to bypass, may result in more severe organ injury and thus be a mechanism for poor outcomes. One such chemical is cyclohexanone. It's an industrial organic solvent used broadly in the production of nylons and paints. Inhalation and skin exposure limits are regulated by the National Institute for Occupational Safety and Health, given its adverse effects on the brain, lungs, kidneys, and liver in animal toxicity studies. But safe circulating levels are unknown. In the healthcare environment, cyclohexanone is often used as a bonding agent to join medical plastic parts such as IV tubing and bags in the cardiopulmonary bypass circuit. Cyclohexanone has been shown to leach from tubing into IV solutions, and cyclohexanone metabolites have been detected in infant urine samples from IVs. Perhaps most interesting, though, is this study where the investigators injected adult rats with an IV bolus of cyclohexanone. This caused significant deleterious cardiovascular effects, including edema, systemic hypotension, pulmonary hypertension, and depressed cardiac contractility at plasma levels of just 51 micrograms per liter. This is shockingly similar to the low cardiac output syndrome we see postoperatively. Now, phthalates and phenols such as BPA and DHEP are also utilized in a variety of common products, including water bottles, baby products, and plastic medical devices. These are biologically active compounds with endocrine disrupting properties, including anti-androgenicity and impairment of thyroid function. Exposure to these substances has been associated with the risk of obesity as well as altered genital and pubertal development. There's growing evidence that exposure both in utero and later in life is associated with adverse cognitive and behavioral outcomes, including lower IQ, problems with attention, hyperactivity, and executive function, and poor social communication. This pattern of neurodevelopmental disability described is very similar to that we see in congenital heart repair in neonates and infants. Volatile organic compounds are organic substances which evaporate at room temperature and can be inhaled. VOCs you may be aware of include formaldehyde, benzene, and cyanide. VOC exposures are ubiquitous and can be exogenous from plastics and adhesives and tobacco smoke, or endogenous through digestion. Just last year, the FDA updated its advice on the use of neonatal incubators due to the potential health risks from airborne chemicals that may be released from the incubators due to published literature describing elevated levels of formaldehyde, cyclohexanone, and other VOCs. So now I'd like to share some of our work with you, but first want to acknowledge the outstanding contributions from my collaborators, Drs. Alan Everett at Johns Hopkins University and Bill Gaynor at the Children's Hospital of Philadelphia. The work I'm about to share with you comes from my collaborations with them and their teams. So in preliminary work, we analyzed serum samples in 115 neonates undergoing cardiac surgery, and we collected preoperative, immediately following bypass, and 12 hours post-op for cyclohexanone and its metabolites. And what you can see here is there was substantial preoperative exposure of cyclohexanone that increased by over threefold to 1,800 micrograms per liter at the end of surgery. This level of exposure is far more than the 51 micrograms per liter reported to have cardiovascular side effects in animals described earlier. Now, this is the same data with cyclohexanone in red with the addition of the cyclohexanone metabolites in other colors. And you can see all of the breakdown product levels peaked at the 12-hour postoperative time point, with two accumulating in much higher concentrations than the parent compound, a process known as stacking. Regarding phthalates, we performed a two-center prospective observational study in 20 neonates undergoing cardiac surgery. We found that exposure to these phthalates and their metabolites, represented by the horizontal color lines in the figure, were present throughout the hospitalization, with large peaks whenever cardiopulmonary bypass was used, signified by the red vertical line, or ECMO, the green vertical lines, with several important differences in magnitude and phthalate exposure between institutions. In another study, we quantified daily urine levels of 20 metabolites of VOCs in 10 neonates undergoing cardiac surgery. And at least 3 metabolites were found in every sample, with a median of 14 metabolites detected in each sample. And levels of 8 of these metabolites were increased when ECMO was used, and alternatively, levels of 6 metabolites were increased when the participants were not on mechanical ventilation and were breathing ambient air, suggesting exposure from local materials in the CICU environment. It's not just that these chemicals are present, we have demonstrated that they are associated with clinical outcomes. So in this work, after adjusting for age and weight at surgery, cardiopulmonary bypass time, and stat category, an interquartile range increase in the mean serum cyclohexanone concentration was associated with a 40% longer duration of mechanical ventilation, 20% longer ICU and hospital lengths of stay, and a 17% reduction in days alive out of the hospital in the first 90 days following surgery. And we published in JAMA Network Open a subset of the first 85 participants that underwent neurodevelopmental testing at 12 months using the Bayley's 3. And we determined that cyclohexanone levels were independently associated with adverse 12-month neurodevelopmental outcomes. And finally, I want to share with you some of the compelling work that Dr. Lauren Jantz is doing at Hopkins. If you've fallen asleep, this is the time to really pay attention. Her work has been really impressive. So she took cyclohexanone concentrations were determined from 25 bags of parenteral nutrition. And essentially the mean concentration in those bags of TPN were 10 micrograms per milliliter. Infant rats were then injected with an equivalent dose of cyclohexanone for 7 days. Neurodevelopmental behavioral testing and brain MRIs were performed when the rats matured to an equivalent of a human adolescent and adult. These are examples of open field behavior evaluation. A rat is placed in the center of the field and their movement is recorded and quantified. The control animals demonstrate normal movement predominantly along the outside wall. In stark contrast, the rats exposed to cyclohexanone pumps are hyperactive, hypermobile, and disinhibited as adults. Let me say that again. These rats received 7 days of cyclohexanone pups. The rest of their environment was unchanged, and this is their behavior as adults. This is scary and looks very similar to the behavior we're seeing in our population. For those that like p-values, these graphs quantify those behaviors. With cyclohexanone-exposed rats significantly traveled more distance, spent more time mobile, and more time in the center of the field. The video at the bottom of the corner is a DigiGait assessment. Rats are placed on a treadmill and their gait is analyzed for multiple parameters. What this shows is that cyclohexanone-exposed rats have abnormal posture, balance, and gait. In other words, they're ataxic. And then to determine the mechanisms for these behaviors, brain MRI with diffusion tensor imaging was performed, demonstrating that white matter tracts are diffusely diminished by cyclohexanone. And you'll have to take my word for it, but these graphs suggest that myelin itself is disrupted, and that was confirmed with electron microscopy demonstrating diminished myelin around the axons. This is a functional MRI of 46 gray matter regions and their connections, with red symbolizing more connectivity and yellow-green less connectivity. And you don't have to be an expert to see that cyclohexanone profoundly diminishes connectivity diffusely with a p-value of 10 to the minus 6. And interestingly, connections in the basal ganglia, which is that bottom right of these figures, are specifically affected, which corresponds to the behavior we are seeing. So we have a challenging path ahead that intersects science, public health, and regulatory policy. And I'd like to conclude with this video that was shared with me by Dr. Cam Sparata in collaboration with the Little Things That Matter team. You can check them out on social media, and it uses lead as an example to highlight the disastrous impacts of toxic chemicals on IQ.
We lost sound somehow, Eric.
Mhm. Now imagine our population we care for with congenital heart disease, with abnormal brain development, little to no bonding at birth, multiple catheters with potential for paradoxical emboli, multiple medications, anesthetics, blood transfusions, cardiac surgery, periods of low cardiac output, analgesics, sedatives, critical care environment, and chronically stressed parents. We have a lot of work to do. Thank you so much.
Wow, thank you, Dr. Graham. I'm gonna completely go off course. Just ask a quick question because I know you can't stay for the whole session. That was incredibly sobering, and terrifying. What do we do? What can we do?
I think that's a great question. I think first we just have to recognize there's a problem. I mean, we have to first admit there's a problem, and then we can't find a solution until we do that. And so there are alternatives to some of these chemicals, so we need to study these and figure that out. I think the important part is it shouldn't be on the physicians and the people using them. This should be on the manufacturers. There should be regulatory processes that put it on them before that like we shouldn't have to prove that they're safe. The manufacturers should prove they're safe before they go out. But we do have a lot of work to do, obviously.
Well, thank you for your work and for bringing all this to light.
Great. Thanks for the opportunity.
Eric, there's a question. I don't know if you've seen this in the Q&A. We generally ask all of our panelists and I'll remind all of the panelists to keep an eye on the box down there on the bottom of your nav bar. It's got questions in there now. And more than one of us can answer those questions. Eric, thanks so much again.
Absolutely. I'll start working on it. Thanks.
Thank you. Next up, we have Dr. Amy Jo Lisanti. She is an assistant professor in the research track at the University of Pennsylvania School of Nursing with a joint appointment at the Research Institution at the Children's Hospital of Philadelphia. She will be speaking to us about the separation of infants from their caregiver. Nice to have you here.
Thank you, Carly, and thank you, Eric, for just your eloquent start to this really important webinar on the ills of the ICU. And my job here is to, as you briefly mentioned at the end, at the end of your talk about the lack of bonding, I'm here to talk about separation from caregivers. And I know that previous webinars have highlighted why this topic is important for examining neurodevelopmental outcomes in infants and children born with congenital heart disease. And so I just highlight this statement for those of you who may not have seen this latest scientific statement from the American Heart Association, highlighting that more than half of children born with critical congenital heart disease develop lifelong neurodevelopmental disorders and disabilities. And it's the most common morbidity that we see in congenital heart disease. Furthermore, CHD is now the most common chronic illness of childhood. So this is an increasingly significant health problem. And as Eric mentioned, we are really trying to identify, we know some of the neurodevelopmental risks, but current research only explains approximately 1/3 of the variance in outcomes. And so we must identify new targets for intervention. Eric highlighted the plasticizers and these chemicals that can have a negative impact on brain development. As we talk about separation from caregivers, I think the most important concept I want everyone to come away from this webinar remembering and understanding is this idea of early toxic stress. Early toxic stress is defined by the American Academy of Pediatrics as a strong, frequent, or prolonged stress response in the absence of the buffering protection of adult caregiving support. So we know that, some stress can even be positive or even tolerable when buffered by supportive relationships. However, stress crosses the line into becoming toxic when there is the absence of protective, nurturing relationships. The eco-biodevelopmental framework posits that infant neurodevelopment is driven by an inextricable interaction between human biological systems and the social and physical environment. And so one of the core foundations to human development is this caregiver buffering the negative effects of stress. Dr. Amy DeGata has articulated this within the neonatal intensive care setting. She has coined this phrase infant medical trauma, which is very similar to this idea of early toxic stress. She defines infant medical trauma as the intertwined and cumulative early life experiences of stress, pain, and parental separation. And she argues this encompasses the potential for alterations in both short and long-term neurodevelopmental and physiological responses. So what does this look like for our infants? If you spent a day in the ICU for even a moment, I don't need to probably spend too much time convincing you that our infants born with congenital heart disease experience profound physical stress. We'll be hearing later through the webinar the different types of noxious stimulation that infants are exposed to. But it is happening in combination with both immediate and prolonged parental separation after birth. As Chetna highlighted in the introduction, under normative circumstances, infants are supposed to be connected to their parent after birth, either through skin-to-skin care and breastfeeding and touch. Yet these infants are immediately separated and then have prolonged parental separation after birth. There's also lack of or inconsistent nurturing caregiving from a safe and stable relationship. So early toxic stress is occurring during this very sensitive period of brain development. We know in normal development, the human brain develops rapidly in this critical early prenatal and postnatal life. During this sensitive period, there is a complex genetic blueprint that directs cellular differentiation, proliferation, migration, neuronal growth, and synapse formation. So early toxic stress can disrupt these patterning processes during this critical period of enhanced neurologic sensitivity. The developing brain appears to be especially sensitive to early toxic stress in the areas of the hippocampus, the amygdala, and the frontal lobes. Early toxic stress can also result in dysregulation of the hypothalamic pituitary adrenocortical axis, as well as, and so that HPA axis functioning can then, when there is dysfunction, prolonged dysfunction, it can result in enhanced risk for subsequent neurodevelopmental delay, cognitive impairment, or mental illness. And so the message here, right, is that immediate and prolonged parental separation is bad. This is bad for our developing brains. Yeah, for some reason, it's become normative in our cardiac ICUs. When I started 20 years ago, I was taught as a nurse to tell parents, don't touch your baby. That was the message. And that is the message that we must debunk, and we must debunk immediately. A note on attachment and bonding. Attachment theory has long established that secure attachment between infants and parents promotes infant stress regulation, and that infant stress reactivity can be mitigated by maternal caregiving behaviors. I would be remiss to not also mention, right? So we've established that this is bad for babies. It's also bad for parents. And I know our focus here is on babies, but I can't help but also highlight the incredible traumatic stress that this is causing for parents. When parents are separated from their infants, they have reduced opportunities for their own bonding to their infant, and parents describe feeling powerless. They describe they have prolonged inability to hold and touch their infants. Unfortunately, we have not had a great way to measure parent-infant separation in the cardiac intensive care unit. I've recently published just a prevalence on skin-to-skin holding, which is just one form of that closeness that we can measure. And the incidence of skin-to-skin care, as we know from our data, is that it happens at only 6% of the time. That when parents report after discharge, that only 6% of them ever got to hold their infants in skin-to-skin care. It's also the lowest reported developmental care practice. So we have so much work to do. Just to quickly highlight the stress experience for parents, as we've looked at many different stressors, it is this idea of parental role alteration where parents are unable to touch, hold, nurture, and care for their children, that in multiple cohorts over and over again, we are seeing significant associations between parental role alteration and anxiety symptoms, depressive symptoms in parents in the ICU, as well as 3 months post-discharge, their anxiety, depressive symptoms, and post-traumatic stress symptoms. And so this is, again, not only important for the infants, but for the parents. And we will, in our webinars in the future, be talking about developmentally supportive care, but I have to highlight here that parent engagement is a core component and is something that we can all be doing in the ICUs today to support and mitigate this experience, whether through skin-to-skin care or through any form of parent caregiving. Nurses have a critical role in this, and we can find ways every single day for parents to be engaged in the care of their infants. This has been highlighted as a critical need through the AHA Science Advisory that was recently published. And so I encourage all of us as we go into the ICUs and we think about how we can mitigate the stress. This isn't rocket science. We must improve the way we are allowing parents to provide caregiving to their infants and mitigating that parent-infant separation. Thank you.
Well, thank you, Amy. Every time you talk, I am glued to every word, and your work is so impactful and powerful. Thank you for all that you are doing. Next up, I would like to introduce Dr. Cheryl Caparola, an intensivist at the Children's Hospital of Colorado, where she is part of the team leading CINCO, which is an inpatient neurodevelopmental care program. She will be talking to us about the sights and the sounds of the ICU. Looking forward to hearing from you.
Yes, thank you again for having me. Hopefully you can all hear me just fine. So I will talk about sights and sounds in the ICU. You would think we live with light, sound, looking at lots of different things throughout the world every day. So you wonder, how can this be bad for us or for the neonate in the CICU? Well, let's take a look and we'll find out. So first, we'll just talk about sound. Knowing that sound is something that is heard. And when we talk about noise, noise is referring to unpleasant or undesired sound. I'm sure we can all think of examples of that. Maybe your children's music or, the construction that's being done on the floor below you at the hospital. These are all things I would consider noise. When we look at the volume of noise, it's measured in decibels, and that is through a logarithmic scale. So for each increase in 10 decibels, that represents a doubling in sound. I have some examples here of what sound can be like. So when we talk about 40 decibels, that would be like a refrigerator running in your home, 70 decibels like a vacuum. We can get up to 90 decibels, which could be a lawnmower outside or a pneumatic drill, just to give you some ideas of what that would be. When we look at noise, excessive noise has been associated with patient discomfort, abnormal sleep, hemodynamic instability. It can contribute to delirium, contribute to post-intensive care syndrome, and disrupt normal growth and development in infants. As early as 25 years ago, it was identified that ORs, PACUs, ICUs are all areas in the hospital that have noise levels that are above the recommended decibel levels. Equipment, this is due to equipment, staff, conversations all around, and both physiologic and psychological effects were noted. When we look at recommended levels for sound within a hospital, the World Health Organization, the EPA, or Environmental Protection Agency, and the American Academy of Pediatrics all have recommendations for those levels. Those levels range from anywhere to 35 decibels at max to 45 decibels for the neonates and infants from the AAP. A reminder, that's close to the sound of a refrigerator or raindrops. So not very loud, not surprising that the sound is often above that. So I'll look at a couple of studies in CICU setting. In 2017, Dr. Garcia Guerra and his colleagues measured noise levels on 39 patients in the CICU in Edmonton. There, they found that sound levels were consistently above the recommended value. On average, was around 60 decibels. There was no difference between daytime and nighttime noise, and there was no difference between open areas versus single patient rooms in this study. Interestingly, but not surprisingly, there was a significant association between average and peak noise levels and the number of sedation PRNs given. The louder it was, the more sedation a patient received. In DC, we wanted to evaluate sound in our CICU and look at its association with sedation as well as delirium and hemodynamics. We performed a prospective observational cohort study over 5 weeks in our 26-bed CICU with decibel meters that recorded the decibel levels every 5 minutes. We had 68 patients that were enrolled with this, with an average daily census of about 18 patients per day. With this, we had 166,000 decibel meter recordings over this 5-week period. Consistent with other studies, sound levels were consistently above the 45 decibels during all times and significantly higher during the daytimes than during the night. Average daytime sound levels was about 50 decibels with a maximum decibel level of around 77. The average nighttime sound levels was 49.5. Really not that different, but was significantly different with a maximum sound level of 70. So quieter than at night or during the day, sorry. We also found that there was an increase in average and with an increase in average and maximum sound levels, there was a predictive increase in heart rate as well as systolic, diastolic, and mean blood pressure. And then lastly, an increase in average and maximum sound levels during the nighttime hours significantly increased the probability of sedation during the following hour. This is consistent with Dr. Garcia-Guerra's study that I mentioned previously. And this is the first study that we know of that links the sound and hemodynamics and demonstrates an increase that increased sound may lead to increased stress noted by the increased heart rate and blood pressure. This overall suggests that if we can decrease noise, there may be a potential to decrease sedation, but also decrease potential stress in our patients. With this, the question is there such a thing as good noise? There are multiple studies, or there have been reported studies looking at different frequencies of noise. There are reportedly maybe properties with green noise or white noise that can help our patients. There have been studies looking at spoken language from parents. We have musical therapists for a reason, and potentially can even look at the range and volume, as no noise may not be good for our patients as well. From here, I'm going to transition to looking at light. When we look at light, the intensity or illuminance is measured in terms of lumens per square meter or lux. Unlike sound, there are no World Health Organization, EPA, or AAP recommendations for light levels. There are some engineering societies that have some recommendations for hospitals. I put an example here in the bottom left of examples. One thing I want to highlight over here is that a lux level of about 100 would be similar to a dark overcast day, where a lux level of 10,000 to 25,000 would be full daylight, but not in direct sunlight. The recommended levels per this society that I pulled has that the recommended level in a patient room is about 100 to 300. So something similar to a dark overcast day. I don't know how you feel on a dark overcast day, but that makes me feel a little tired. When there have been studies looking at effects of light on patients, one thing to note about light is that it's the most important factor that contributes to the circadian rhythm. This is determined by the timing, intensity, and duration of light. It requires that there's bright light exposure during the day of at least 1,000 lux. So similar to daylight, or actually a lot less than daylight, and dim to no light overnight, so less than 10 lux. At night, short bursts of even 5 minutes of light of even 100 to 250 lux, so the dark overcast day can disrupt that circadian rhythm. In a study looking at rats who were exposed to constant darkness or constant light, they had an increased mortality after sepsis of about 50%, while rats who were exposed to a day-night cycle pattern, like we might experience in normal life, who had 5 to 10% mortality. When there is exposure to bright natural light or windows in adults, there is noted less delirium, less postoperative pain, reduced mortality, and reduced mortality after myocardial infarction. In a study that looked at cycled light, they noted improved sleep, improved alertness during the day, and even shorter times to discharge. Very quickly, I want to highlight sleep because light has been reported as one of the biggest contributors to lack of sleep in the ICU. And what we know is that in an ICU, patients experience significantly decreased sleep quantity and quality. They have increased daytime sleep. This altogether alters the circadian rhythm and melatonin synthesis. Sleep studies of patients in the ICU demonstrate absence of deeper slow sleep and rapid eye movement sleep, and have significant amount of nighttime arousals, up to about 20 per night. And then studies show that deep sleep deprivation and disruptions are associated with increased morbidity, anxiety, depression, increased delirium, increased pain, and impaired immune response. And as you can see, some of that is similar to what we have with increased light, just highlighting how the light exposure can and sleep are associated. Really quickly, we can look specifically at light in the ICU. There are no studies looking at cardiac ICU patients. There are only 2 studies I can find looking in the PICU, several from the NICU and several from the adult. The good thing out of these papers is that they do find that there are day and night variations. However, during the daytime, light is dimmer than ideal. In one of the PICU studies, the median level of light was 27 lux. Remember that 100 is an overcast day. And overnight, it should be less than 10. So we are closer to nighttime level during the day. And in one of the NICU studies, the light level rarely got over 75, again, lower than that overcast day. They also found that daytime natural light was intentionally decreased. Now, maybe it was not fully intentional, but what they said is that often the blinds are down over windows, probably something that wasn't even thought to open. And then when they looked at nighttime levels, it is brighter than ideal, although the one study that noted the lux overnight was appropriate at about 4 lux. I don't know about you though, when I walk through our CICU, the TV's on the room, the monitors are light, and then the hallway lights definitely seep through. I can't imagine it's only 4 lux in our ICU rooms. When they've looked in adult studies making lighting modifications, sleep significantly improved with the cyclic lighting, so having day and nighttime lights. Melatonin levels were actually influenced by light intensity, and when they had brighter light cycling during the day, there was less delirium. With this, I think we should consider opening windows, using brighter light during the day, and decreasing as much light as possible at night, maybe even considering sleep masks. We use them at home. Babies can use them in the hospital too. So in summary, noise has consequences. There's changes in hemodynamics and increased sedation requirements. We could probably use further investigation looking at different types of sound and their benefits. And then light also has consequences, can disrupt our sleep, alter our circadian rhythm, and ultimately have increase in delirium and pain. We should consider cycling light and increasing the light during the day specifically, and decreasing it at night if possible. Thank you.
Thank you, Cheryl. That was excellent. And I know even myself, after a 12-hour shift in the ICU, I am completely overstimulated by the lights and sounds. So I can't imagine what these poor babies are going through. Thank you so much. I'd love to introduce our next speaker, Ms. Shannon Overpeck. She is a dedicated bedside nurse with over 20 years of cardiac ICU experience. No doubt our bedside nurses are the best champions in neurodevelopmental care from the bedside. In addition to being a bedside nurse, she is also a board certified lactation consultant, and she will be co-leading the Cardiac Newborn Neuroprotective Network's first ever multi-center skin-to-skin-a-thon for babies in the cardiac intensive care unit, which I know that Chetna nicely plugged in the beginning of the program. So we all look forward to your leadership on that, and can't wait to hear the outcomes of that very exciting program. Shannon will be discussing the infant's experience with a lack of positive touch in the ICU.
Thank you so much. All right, let me share my screen. Mhm. So I'm excited to share with you, this is a big heart and passion of mine. And the title of my talk is actually The High Cost of Positive Touch Deprivation in the CICU. So in the absence of positive touch, all our infants have is negative. And I'd like to start this talk on actually sharing from the perspective of the neonates that we actually take care of. This is baby J, 5 days old, post-op day 1 from an arterial switch, and intubated on pressors and has never been held. This is what her morning looks like. 5:30 a.m., it's chest x-ray time. She's startled awake, hands to her face and mouth to hold her ET tube, and her head to be placed midnight. Her heart rate jumps to 180. She desats to 85. Her arms and legs flare away from her body, unsupported. She needs to be suctioned. But still, the only touch that somebody is doing for her is holding her head and ET tube. She needs PRNs. 6:10, vital signs finally go back to baseline, but her EEG leads are out of place and the EEG tech needs to come and fix that. She startled awake once again with cold gloved hands, starting to rub and scrub on her sensitive scalp. She coughs and needs to be suctioned again. 6:50, cardiology comes to do their assessment. Cold stethoscope placed on her chest and cold gloved hands poke for pulses. 7:30 a.m., the day shift nurse needs to do her assessment. More cold gloved hands, another cold stethoscope, and now the art line is dampened and not reading. So now we have to do non-invasive blood pressure, squeezing her leg every minute since she's on pressors. It is now 8 o'clock. The RT comes in. It's time for them to do their assessment. We have cares, oral care, and more suctioning. Now the ET tube tape is loose and needs to be retaped. She will need more PRNs. 9 a.m., time for bedside rounds. More assessments, more cold gloved hands, more cold stethoscopes. We also notice now that her ST segments are looking elevated. The EKG tech is called to the bedside. 10 cold stickers are placed to her body while the weight of the cords pull in her skin. Her parents wake up and come to her bedside. They are told not to touch her right now because she has been unstable when awake. And we had just given PRNs. 10 a.m., baby J has been touched well over 20 times in the past few hours, but not one of them has been positive. Let us remember that neurons that fire together wire together. So why is touch important and why does it matter? I'd like us to think when we touch the skin, it really is like touching the brain. And to touch, touch is important for infants' development and from birth all the way through life. It is the first sensory system to emerge, and it is the most developed sensory pathway at birth. Touch is critical for the caregiver-infant bond with long-term consequences for the child's development, especially emotional and cognitive, in the emotional and cognitive domains. Sense touch is so important in infancy. How we do, what we do, especially in the ICU, matters. Infants in the NICU are often exposed, or in the CICU are often exposed to complex, multisensory, and painful stimulus. And these stimulus are frequently derived or deprived of developmentally supportive stimuli. NICUs and CICUs, infants are commonly deprived of positive touch experiences such as hand containment, kangaroo care, or skin-to-skin care, and swaddled holding. Frequent stressors in the ICU can permanently and negatively alter the infant's developing brain. In a study from Dion et al., we see that we look at what the percentage of time infants in the ICU are experiencing different types of touch. One being negative, things like cares, assessments, tests, etc., or a type of to comfort touch, which would represent comforting touch, but in response to a discomfort. Or there's an exclusive comfort touch, which is something like skin to skin. In the daytime, it is noticed that 60% of an infant's day is full of negative touch. 30% is to comfort, but only 10% is exclusive for comfort. I couldn't imagine at home my infant growing, when they were little, only having 10% of their time being actually like held or comforted, for their not in response to pain or discomfort. And at night shift, and I'm a night shift nurse, so that hits even harder home for me, 86% of our time, of the infant's time is spent in negative touch, while 11% is for comfort and only 3% is exclusive for comfort. Neonates are exposed to roughly 70 stressful procedures every day during their hospitalization. And 89% of these times that infants are touched in the ICU are through gloved hands. It is imperative that we remember every sensory experience is recorded in the infant's brain, and it leads to a behavioral response. The lack of positive touch results in early toxic stress, which we heard a little even more about from Amy earlier. And this early toxic stress has been found to negatively affect epigenetics. A review of studies by Mullen et al. Found that early toxic stress in the NICU alters DNA methylation of genes responsible for regulating serotonin, dopamine, and cortisol. This results in poor self-regulation of our infants. They're easily irritable, they have poor movement quality, and less sustained attention. At the bedside, this is the infant that is always irritable, so difficult to calm. And these behaviors can lead to hemodynamic instability, poor PO readiness, poor weight gain, and overall poor neurodevelopmental outcomes. A study from Pavazzi et al. Found that when positive touch is absent during a task such as suctioning, moderate pain scores were higher by 31%, and severe pain scores more than doubled. It is important to recognize that touch from healthcare persons and parents are not equal. We learned a lot about that earlier with Amy Jo. And so this disruption in early social sensory input during infancy has severe developmental consequences through a lifespan. Infants who are deprived of touch delivered by a parent are at high risk for sensory processing problems. Maternal contact, specifically high levels, not just occasional maternal contact, is epigenetically protective against early negative experiences that our infants are, obviously what we've talked about, very exposed to in the ICU setting. Practices like skin-to-skin care, direct breastfeeding, and infant massage can restore hypomethylation of DNA. And so Amy Jo had mentioned it earlier, but even though we know that these types of practices like skin-to-skin is important, only 6% of infants do any skin-to-skin with their parents in the hospital setting, which is really sad. In 2023, a single center CICU by Elhoff et al. Had infants held by parents, and they had a statistically significant decrease in heart rate and increase in years. They also noticed that other vital signs showed improvement, but they weren't statistically significant in that study. Providing parents opportunities to support and soothe their infant during cares can reduce infant stress, promote bonding and attachment, and may reduce cardiopulmonary instability resulting from stress response. The lack of positive touch experience also has a negative impact on their parents. This disrupts bonding between parents and infants, and it contributes to that sense of loss of their parental role, and they can experience mood swings, stress, feelings of incompetence, anxiety, and even major depression. And on that happy note, I thank you for your time, and I will pass on to our next presenter. Thank you.
Thank you, Shannon. That was excellent. Next, we are going to hear from Melissa Jones, who is a nurse practitioner and the director of the Neurocardiac Critical Care Program at Children's National Hospital in Washington, D.C. And Melissa is currently a PhD candidate at George Washington University, focusing on parent stress in the CHD population. She will be talking to us today about sedation exposure.
Melissa, before you get started, I just want to say on Shannon's talk, Shannon, I like the way you put it, that it's not that we're not touching the babies, we're just not providing that positive touch, which is such an important distinction. So thank you.
You're welcome.
Wow, this session has been so inspiring. I feel like I'm madly texting all of my colleagues with lots of ideas. So thank you for including me in this really incredible webinar. So I'm going to talk about pain and sedation in the CICU, which I think goes along nicely with previous talks. So as we know, babies are born with over 100 billion neurons, and the number of connections that happen in infancy are more than any other time in life. These synaptic connections are the architecture for all future brain development. And plasticity offers an opportunity to alter the functionality through the experience. So we'll discuss how pain and pain medications alter these synaptic connections. An important concept to remember is that newborn sensory circuits are excitable. However, their neuroinhibitory pathways are continuing to develop in the postnatal period. So this may limit their ability to filter external stimuli and increase their pain susceptibility. As with so many areas of neurodevelopmental care, the NICU is way ahead of CICU. The studies that I'll present are mainly involve preterm infants, and maybe that's okay for us to extrapolate this data from the literature, given that full-term infants with complex congenital heart disease have demonstrated brain dysmaturation similar to that of a 34 to 36-week preterm infant. Early NICU studies compared procedural exposure to opioids to no pain medications. And many of those studies illuminated the negative consequences of pain in both the neuroprotective and the negative consequences of opioids. What makes things more complicated, I think, in the CICU is that in addition to procedural pain management, many of our patients are exposed to repeated painful stimuli, chest tube placement, reintubation, ECMO cannulation. And they're also subject to long-term mechanical ventilation. So I think those are important considerations and distinctions between our population and the NICU population. And we have to be honest that the NICU does a much better job of environmental modifications, which tend to be much more brain-friendly. In the CICU, we're often faced with the challenge of balancing risks associated with pain and those associated with pain medications. None of us want our patients to experience excessive pain, but prolonged exposure to pain medication also carries serious consequences to the developing brain. So we're going to first start with the effects of pain. So what happens to the brain when it's exposed to cumulative pain early in life? This is a really busy image, and it's taken from a 2021 systematic review on the impact of cumulative pain in brain development. The investigators included both human studies involving preterm infants and animal studies in this review. On the left side of the slide are changes discovered in the neonatal brain, and on the right are those changes noted at school age. You can see that early exposure to pain affects brain macro and microstructure and also brain metabolism. So pain is associated with reduced total and regional brain volumes and metabolism. What do these metabolic and anatomic changes mean for neurobehavioral functioning later in life? This review by Victoria et al. Victoria and colleagues describes a phenotype of hypo and hypersensitivity to acute and persistent pain later in life. These changes are thought to be related to dysregulation of stress hormones and endogenous opioids related to early pain exposure. Their findings indicate that pain in early life significantly increases the risk for post-traumatic stress, anxiety disorders, and depression. This suggests that there is a pain imprint that lasts well into adulthood. Investigators in Italy conducted a prospective case-controlled study comparing children who were exposed to pain in early life to those who were not. And early pain was associated with decreased connectivity to the thalamus, which in this cohort was associated with lower motor scores. Okay, so pain is bad for the brain, and we use pain medications to treat pain, but those, of course, come with additional risk. Both human and animal studies describe the association between opioid exposure and apoptosis of microglial and neuronal cells. Microglial cells are important for the brain's immune function. They respond to infection or injury and promote recovery. These cells are also responsible for refining neural pathways through pruning. Neural cells are obviously the fundamental building blocks of the brain and transmit signals through the body and establish important connective networks. Studies also describe alterations in neuroplasticity in the postsynaptic sites of the limbic system, which are associated with opioid exposure in the developing brain. Changes that occur during synaptogenesis persist into adulthood and impact areas of the brain that regulate learning, motivation, and reward. A recent paper, and the first that I'm aware of in our CHD population, examines the effect of opioid exposure in the first year of life. And they found higher cumulative opioid exposure in the first year of life was associated with lower language, cognitive, and motor scores at 2 years of age. Okay, so let's look at benzodiazepines. This study looked at 138 preterm neonates. They had brain MRIs at 32 weeks and then at term, and then were followed for 18 months for neurodevelopmental testing. And what they found is that the total midazolam dose predicted hippocampal volumes, and that the midazolam dose was associated with macro and microstructural changes and poor neurodevelopmental outcome as a result of hippocampal dysmaturation. This part of the brain is associated with or is critical for learning and memory, and this study found lower cognitive scores in the cohort. In 2016, in the United States, the Food and Drug Administration issued a warning about midazolam use, stating that repeated or lengthy use of general anesthetic or sedation during surgeries or procedures in children younger than 3 or in pregnant women during their 3rd trimester may affect development of children's brains. This warning really impacted practice, and I think many of us have significantly reduced the use of benzodiazepines in our patient population, and have really substituted dexmedetomidine. And quickly, a few recent studies about delirium in our patients. The first study here identified a nomogram to predict the postoperative delirium in pediatric patients who underwent cardiopulmonary bypass. And what they found is that the only medication that was predictive of delirium was midazolam. The second paper published in Nature found that the association between CAPD scores and a brain injury biomarker. The investigators suggested that their findings emphasize the need to monitor CAPD scores as another tool to assess brain injury in neonates after cardiac surgery. So I have 2 closing thoughts. Are we adequately assessing the problem, and how do we expand our tools for managing comfort in the CICU? We're all familiar with the constellation of experiences that can cause pain in the CICU. And though these experiences or feelings are very different, they may be expressed, assessed, and even treated as pain. Assessing pain and discomfort and agitation in CICU patients remains one of the biggest challenges and makes precise treatment very difficult. And given that we know the risks of pain and pain medication, we need to rethink our assessment and treatment of pain, agitation, and discomfort, and expand our tools to provide comfort and minimize stress. So instead of limiting our support to either pain medications or allowing our patients to suffer in pain, we might consider environmental and developmental changes to reduce stress. A lot of these have been talked about by the speakers before me, but I think just to reiterate and re-emphasize the value of engaging parents as buffers to the environment, using developmental positioning and containment, skin to skin, positive touch, non-nutritive suck, natural lighting, parent voice and engagement. And of course, we'll use pain medications as needed, but I think when those should be held for when we actually assess the patient for pain, and other etiologies for pain or agitation are ruled out. I'm really looking forward to the next webinars because I think we'll really get into the some of the things that we can do and that some places are doing to modify this experience and improve comfort in patients. So just in summary, pain in early life negatively impacts brain development by reducing synaptic connections and brain volume in several regions of the brain. Long-term consequences of pain include motor dysfunction, post-traumatic stress, anxiety, depression, and an altered stress response. Further studies are needed to characterize the impact of pain on the developing brain, specifically in infants with CHD. Apoptotic neurodegeneration is associated with the use of sedatives and analgesics in neonates and infants. These changes can persist into adulthood and impact learning, motivation, and reward. Accurate assessment of pain and discomfort may help us to determine an effective intervention to provide comfort. And studies are needed to examine the best practice for comfort management while reducing opioid and benzodiazepines in this population. Here are some references, and thank you.
Thank you, Melissa. And there's a couple questions for you in the Q&A. And just a quick plug for our last webinar in the series that'll be in June. It'll actually be talking about optimizing analgesia, sedation, and non-pharmacologic ways to manage pain and agitation. So that'll be a really nice complement to your talk just now. Thank you, Melissa. All right, Carly, you want to get us introduced to, it'll actually be Courtney Jones will be our next speaker on feeding disruption.
Okay.
Sam's just jumping the gun. She's ready to go.
For a minute. I was getting excited about your talk too, Sam. Next up, we have Miss Courtney Jones, and she is an internationally known and published feeding therapist. And if you look up most of the papers written about feeding and CHD, she is the lead author on those. So she has been a power horse in contributing to our science. So thank you. She's going to focus on cardiac intensive care and acute care for feeding infants with congenital heart disease. And she will be talking to us about feeding disruptions that infants with CHD experience. So looking forward to hearing you talk.
Courtney, before you start, Courtney, this is Gil. Just wanted to let our people know there are a number of people jumped on late. I think that was a time zone, daylight savings time, and they can all go onto the YouTube channel to see the final version. And we are going to expand the session to about 11:45. So I look forward to the next three talks, and especially yours, Courtney. Thank you.
Thank you. And thanks, Carly, for the introduction. This timing is just perfect. I can't believe I get to be after everybody that's done such a good explanation of all the things going on. And now let's talk about how those things that we've been talking about. Oops, I lost my screen. Hold on one second. About how feeding disruptions happen with infants with congenital heart disease. So, in order to do that, I want to do a quick description of typical feeding advancement. For infants without congenital heart disease, the first 14 days are spent establishing breastfeeding and bottle feeding, and typically regaining birth weight by 14 days, which you can see happen for this infant in this chart. I'm showing this progression with weight trajectory because it's well known that the impact of growth on the brain development, especially is impactful on 3 months and our birth to 3 months. So what does it look like for the infant without congenital heart disease? They may be born in a hospital or birthing center and remain near their family They may receive medical support for a couple days and then discharge home with routine pediatrician visits, which I thought Chetna did a good job of explaining. You still get vaccinations and that sort of thing, but you're pretty much typically near your family. Feeding, they're not Q3, but they're QQ. And it's not an official term, but I wanted to highlight the CUE part because it gets confused with the English word for standing in a line or the letter Q. But Q-based feeding typically occurs every 1 to 2 hours in that first week of life. Infants move freely around the home with lots of opportunities to experience different positions, different vestibular input, all contributing to their brain growth. They also experience light, sound, smell of their home, which might be the food the family enjoys, the smell of the family members, and most familiar smell their mother. And it may even include a friendly lick on the face of their family pet. But the point of this whole picture is that the baby is leading the show and telling the family when they need to be fed. So now let's look at a growth trajectory for an infant with congenital heart disease and think about the disruptions for our infants with establishing feeding. And I want to be clear that we're not just, if we didn't have these disruptions, we wouldn't have day of life 30s and beyond. And the care provided is, of course, necessary for survival. And being aware of all these disruptions allow us as caregivers to have the insight to improve long-term impacts with their altered trajectory. So as you can see on this graph, the first 14 days look a little different with the necessary life-saving measures. There's some extra weight gain or fluid in this example, and the infant didn't regain birth weight and had some difficulty maintaining that 25 to 35 grams per day growth trajectory. So let's maybe look at the possible reasons why. And the first might be feeding. So preoperatively for this little kid that I took the example from, some of our infants are allowed to, when they're born, they're transitioned to a medical team, lines are placed, and then additional imaging is done. And they may be allowed to orally feed or have oral immune therapy or skin to skin. And they may not. It's just different in every center. And then there may be a period where they're MPO, and this is when this little kid had a surgery at 3 days. And then after that MPO period for us is typically when the chest is closed and they're off medications. TPN and lipids are started, and they may start trophic feeds through the feeding tube. The next step would be maybe the longer step, which is when feeding is condensed and we're looking for those oral feeding readiness cues. So some of the things that can come up during this period that relate to feeding are they may need a swallow study, they may have complications such as neck or a chylothorax or a vocal cord difference. So moving on to respiratory, kind of overlapping at the same times, this little one was on high flow when they came in. They were intubated for this period. I went to CPAP and high flow and also went home on low flow nasal cannula. Melissa just did an amazing job of talking about sedation and medication. And that's really important to think about how that's impacting the baby's readiness for eating. For example, if they're on a medication that maybe makes them more apneic, or if they're on a medication that makes them more sedated, or sometimes PG has been reported to just kind of make you feel sort of achy. What other medications are they on that maybe make them not safe for having food? And then the whole process of weaning, again, Melissa did a great job at talking about how that impacts their state and their alertness for wanting to eat by mouth. And finally, most of our kids go home on something just to help with that long-term medication. And lastly, I wanted to add on here, just this part of it, the mobility. If you think about the baby at this time frame from 0 to 3 days, they might get out of bed 0 to 3 times a day. When they're intubated, possibly could be 0 or 1. And then hopefully they start to get out of bed more. But I think what's really interesting is thinking about all the experiences you get with that movement. And if you were to track how a baby moves when they're at home versus a baby at the hospital, it's really striking about how much they're missing from a vestibular standpoint. I also wanted to mention, what is that baby smelling? What are the sounds? What are the light that have been described so well? The family separation. How is their immature brain development metabolism affecting during this time period? And now, after this presentation, I would add what the first presenter said about the plasticizers. So, kind of going through what this looks visually and just talking about a little bit is like thinking about what this little baby, what pre-op feeding looks for them. What does their mobility look like? How does it look like with parent separation and noxious stimulation and increased stress behaviors? And what's going on with their brain development and metabolism? The next would be, we have to acknowledge the life-saving mismatch. They need all these interventions for life-saving, but can we balance out that mismatch of and support not only everything that everybody just said, but also their feeding? When we're able to thoughtfully modify interventions for highly vulnerable infants with congenital heart disease and their brain development, and then balancing that highly sophisticated medical for survival. We can't dismiss the infants, what they've been through, and listen to their voice in only the way that they can talk, which is through their cues. Also wanted to talk about, how they transition through states, which we sort of did. And again, just making that plea for how we're following the infants' cues and how they're able to transition through states and learn this skill of oral feeding. So these are the pictures of our true long-term goals: safely feeding infants supported with developmental care and positive feeding advancement. And when you see the disruptions, it may highlight to all of us why our infants may not be behaving as we expect, and be able to honor their cues as individuals and understand why they may look different than our infants without congenital heart disease. Sometimes it feels like the perception is that we're just these normal infants, but now we must acknowledge and honor what they've been through. And this little guy on the very end of here, the last one to pop up, was that very first baby that I showed. So that was fun to see him at the end. So I also wanted to mention too, going on what Melissa said, that, we're teaching the baby's brain a pattern, and the brain is learning a pattern that goes into adulthood. So I'm always asking myself, what pattern do we want this baby to learn? And what pattern are they learning right now? And hopefully the goal being safe, positive, trusting, advancing, and feeding. So I'm really excited for the more to come with the Congenital Heart Academy series in April, and discussing what we can do to help. And looking forward to any questions. Thanks.
Thank you, Courtney. Food is love, as we like to say in our ICU.
Yeah, and it's really important for parent and infant bonding that the parent is able to participate in these early feeding exposures, and when it's disruptive, it's disruptive to the family as well. And thank you, Courtney. That was an excellent presentation. We appreciate it. Next up is Dr. Sam Butler. And she is a developmental and clinical psychologist, associate professor at Harvard Medical School, and the director of the inpatient neurodevelopmental program at Boston's Children's Hospital. She's also the director of the NIDCAT Training Center at Boston's Children's Hospital and the co-vice chair of the Cardiac Neurodevelopmental Outcomes Collaborative and immediate past chair of CN3. And we will be looking forward to your discussion about disruptions of sleep in the ICU and its impact on brain development.
Great. Thank you, Carly. I hope everyone can hear me okay. So good morning. Today I'm going to be discussing a critical yet often overlooked issue of infant sleep in the hospital. So we're going to start, let's make sure I can actually, there we go. We're going to start by doing a little imagination. So imagine this is you, it's the middle of the night, you're in a deep sleep, you're warm, you're comfortable, you're in your bed. Suddenly, without warning, someone enters your room. The overhead light goes on, light floods your eyes with brightness. Before you even have a chance to react, they pull the blankets off of you and expose you to the cold air. And without a word, they press a cold object against your skin. Maybe they adjust your position, turn you from one side to the other, and they could even start poking at you. So your heart is pounding, your body is tense, this is jarring, this is unsettling. And now imagine that this is just one night. This happens several times a day. And even when you close your eyes again, you know it's only a matter of time before someone else enters and you are woken up again. How would you feel? Would you trust that bed is a safe place? This is exactly what happens to our infants in the hospital. But unlike us, they cannot understand what is happening. All they know is that sleep, something that should be safe and restorative, becomes unpredictable and stressful. So while sleep is crucial for infants in the hospital, we tend to fail to protect it. And so we all learned in our intro psych classes about Erickson's stages of psychosocial development. And we know that that newborn stage is trust versus mistrust. That one thing that baby needs to learn in the newborn stage is, can I trust the world? And their developmental task is the infant must learn to trust caregivers who consistently meet their basic needs, leading to believing that the world is safe and that people are dependable. So if we think about sleep, just as infants rely on caregivers to establish trust, they also depend on a consistent quality sleep to support their brain development. Sleep is not just rest, it is an active and essential process of growth. During sleep, neuronal connections are formed, memory is consolidated, and learning is enhanced. Studies have shown that sleep also plays a role in synapse formation and overall brain function. Growth hormone secretion peaks during deep sleep, supporting growth and weight gain. And sleep is crucial for emotional regulation and immune functioning. We know that infants require, right here, the newborn, about 14 to 17 hours a day of sleep. And by 4 months, it's 12 to 15 hours a day of sleep. This is quite a bit of sleep. We also know that in the hospital, infants have difficulty falling asleep, difficulty staying asleep, and problems with early awakenings. Infants in the hospital, have about 38 clinical procedures a day, 16 of those thought to be painful and affecting sleep. The most procedures occur less than 30 minutes apart, and vital sign checks and medication administration often wake infants due to a set routine. The CICU infants can experience nearly 100 sleep interruptions per day and an average sleep episode of only 37 minutes. So if we think about what kind of sleep interruptions are we talking about, there's three main factors. There's the environmental factors, there's medical interventions, which are necessary but frequent, and there's stress and pain, as we already heard, from medical procedures, separation from caregivers, discomfort. And we already heard about most of this from Cheryl, but we know that sound is affecting sleep, that the hospital noise significantly reduces sleep quality, and that both infants and parents suffer from poor sleep in the hospital, and that there's an impact of light exposure, that constant artificial light, even when it's low, affects circadian rhythms, and that hospital lighting at night suppresses melatonin, making it harder to fall asleep and stay asleep. And that light at night or during sleep times, during naps, delays sleep onset and shortened sleep duration. And we also need to remember that when we talk about, sometimes we want to protect the infant, there is a reflex to swat something over your face. So when we use some of these eye shields, I think it elicits that swat. We actually look for this in the newborn assessments. We see how well they can swat something that is over their eyes. So when we do use these, we need to be careful that we're not then bringing on another stressor. And so also, despite the well-documented impact of sleep disruptions on patient health, sleep patterns are often overlooked in clinical documentation. And without that routine monitoring and recording of sleep, healthcare providers miss a crucial opportunity to identify disruptions and implement target interventions to improve patient outcomes. So in terms of sleep deprivation, so what happens if you don't get enough sleep? We know that there are short-term consequences of delayed brain development, poor weight gain, higher risk of delirium. We also know that there are long-term consequences which are weakened immune function, slower healing and recovery, emotional dysregulation, and trouble with attachment. And I could not give a talk without mentioning safe sleep. I know that is not the focus here, but I have to say something. We know that sleep is frequently disrupted in hospitals, but even when they do sleep, how are they sleeping? And it matters. In the ICU, critical ill infants obviously need the supportive positioning and nesting to promote comfort and stability. However, as infants recover and approach discharge, it's crucial to transition them to safe sleep practices aligned with the AAP guidelines and adapting them for sleep at home. So modeling safe sleep at a time of discharge home ensures that parents are prepared to continue safe sleep practices at home and reduce the risk of SIDS. And just reiterating, obviously, this is what we want in the ICU, but thinking about going home and what it means to actually provide that safe sleep environment. We know that children that have congenital heart disease, infants, are at 2 to 5 times greater risk of SIDS, and that SIDS continues to be the leading cause of death in infants in the United States. This is an example of just a bed here at our hospital and how right before going home, this healthy baby is not quite engaging in safe sleep. And we even did an intervention here where we started at 9% hospital-wide in safe sleep, and after intervention got to 53%. One of our biggest violations was that elevated head of bed at discharge, and parents were copying that going home. And this was found in other hospitals too. And that we know that post-discharge, parents are likely to do the back to sleep. They know about back to sleep, although they're less likely to follow other recommendations such as the flat sleep surface and the removal of soft bedding. So I think it's important that we talk about this too. So just in a quick summary, why sleep matters. Sleep is crucial for growth, healing, and development. Environmental disruptions and procedures cause frequent awakenings. Disruptions in the hospital prevent infants from restorative sleep. And safe sleep prior to discharge sets the foundation for safe sleep at home. So as we think about patient-centered care, I challenge all of us to reflect on how we can make hospitals a more sleep-friendly environment for our youngest patients. By prioritizing sleep, documenting sleep, protecting sleep, we can enhance developmental outcomes and improve overall health. So thank you.
Amazing, Dr. Butler. You know, 2 things. One, sorry, I know we're going a little bit over, but I love sleep. So your talk was very concerning. I would not be a happy camper if I got that little sleep. And then the other thing, you know, I always think about something that you said towards the end of your talk, that all the time in the CIC, we have these kids with head of bed up, all this stuff in the crib and in their nests and all the different things. And then we expect them to take their kids home and not do any of the things that we've gotten their kids used to for their lives. So a really important point. So apologies for going a little bit over, but hopefully everyone can stay on for our next and last very exciting speaker, Dr. Stephanie Hellman. She is a postdoc clinical and translational science fellow at the University of Pittsburgh School of Medicine. Her research focuses on early recognition of temperature instability. She'll be discussing the importance of temperature regulation for infants in the ICU. And, you know, I'm really excited about this one because I have to admit, this is not something I had really thought about until it was brought up. And I was like, oh yeah, like I said at the beginning, we're always obsessing about keeping our babies not in the ICU warm with socks and hats, as my mother would like to say. So thank you, Stephanie.
Thank you for that introduction. So yes, again, this morning we're going to discuss temperature instability in the postoperative neonate with congenital heart disease. And I do want to preface my talk in saying that I am not a neurodevelopmental expert, but I am building a new program of research that may have implications for neurodevelopmental outcomes, but these links haven't really been made yet. And so, before we dive into the postoperative neonate and their risk for hypothermia, I think it's important to understand that even in healthy neonates, they have this baseline risk for neonatal heat loss simply because they have more skin surface area compared to their body mass. And so in the home environment, we do lots of things to mitigate this heat loss. We do skin to skin, we add layers, we clothe, bundle, and contain. Unfortunately, in the immediate postoperative period, we're all familiar with this picture. We're totally unable to do skin to skin and clothe, bundle, and contain while the neonates are in this 24 to 48 hour period after surgery. And so not only do the neonates carry this baseline risk, they also have elevated risks for heat loss because we have them completely exposed to the environment. And so we use warmer beds that emit radiant heat to mitigate heat loss. And I think that we're doing an optimal job at maintaining normothermia. However, there's really no literature that can speak to whether or not we're being effective in this way. And so all of the temperature-oriented related research in neonates is done in the NICU patient population, and they almost always will exclude babies with congenital heart defects. In our patient population, our literature around temperature and thermoregulation and hypothermia use that's intentional is really focused in the operating room and around cardiopulmonary bypass. So how low can they go for how long before we start running into problems in terms of hypothermia use? But understanding what temperature does in the postoperative environment is not documented. And so in our patient population. So we're really embarking on a new journey, and it's my goal to take a stepwise approach using sophisticated machine learning tools. And we really need to generate new knowledge and evidence simply when there is none, specifically for neonates in the postoperative period after they've had bypass surgery. And so right now we need to establish ground truth in two ways. We need to collect all the temperature data that we can and understand the patterns. So are there babies that have similar temperature patterns? We're interested in the patterns because then we can understand, are there specific characteristics about these babies that can help predict whether or not they're going to experience hypothermia in the postoperative period? Second to that is we need to really establish a data-driven definition for hypothermia. So there's lots of disagreement in the literature in terms of like, what's hypothermia? Is it less than 36 degrees? Is it less than 36.5? And I think for us as clinicians, really wrapping our heads around the importance of half a degree or the 1/10 of a degree, is that important and does it matter? So we need to leverage lots of data to do this, and this is very good for machine learning. Fortunately, we want to investigate a vital sign, and so we have lots of data in the medical record and the CR monitor, and even in the warmer beds, we can get that data out of the warmer bed. And so after that, we need to ask ourselves, well, why do we care? Do we care about temperature? And the way that you answer that is you evaluate its prognostic value on outcomes. So if we have these unique patterns, do they have any influence or association on outcomes? Next, we need to assess clinical practice. So I have preliminary data that shows that we're not using our warmer beds in a standard way. And that was published in the summer, and I'll share that publication with you next. We also need to make our measurements precise and robust. So if we're going to predict outcomes using temperature, we need lots of measurements. We need to provide ironclad and explainable evidence. And what do I mean by explainable? Well, when you use machine learning models, you have to be able to explain what you put into them so that you can understand the output. And so we have this saying, garbage in, garbage out. So if what you're putting into the machine learning is not robust, then your outputs aren't going to be trustworthy and accurate. What do I mean by ironclad? Well, as I mentioned before, all of our temperature research that is oriented around neonates with congenital heart defects is really happening and oriented around cardiopulmonary bypass. And so we know that hypothermia, intentional hypothermia in that environment is highly regarded and it's used widely. So if I'm going to come to the table and say, you know what, unintentional hypothermia, like the kind that we don't know that's actually happening, and maybe it's happening for a prolonged period of time, maybe that is a problem. I better make sure my evidence is strong. And then in doing all of this, we can translate our findings back to where it all began, and that's at the bedside. So it's not all bad. We do have some evidence. My colleagues and I published this paper this summer, and we performed a study in 450 neonates at a single pediatric center. And we collected tens of thousands of temperature data points in the first 48 hours after the babies had their cardiopulmonary bypass surgery. And we used an unsupervised machine learning technique called group-based trajectory modeling. And unsupervised machine learning simply means that you don't know the outcome. And so you're really exploring longitudinal data. And we were able to find 3 distinct temperature groups. And one of them we qualitatively labeled persistently hypothermic. So they arrived to the unit hypothermic after surgery and they stayed hypothermic. Those babies were at 3 times higher odds of experiencing a postoperative complication compared to their normothermic counterparts. Here is just a slide with our sample characteristics. And the outcomes that we evaluated, so again, this was the persistent hypothermia group compared to the normothermia group. They were at higher odds of cardiac arrest, actionable arrhythmia, delayed first successful extubation, prolonged cardiac ICU length of stay, very poor weight gain, 30-day hospital mortality, and we also created a composite outcome as well. These persistently hypothermic neonates were also characterized by having greater odds of having a lower gestational age, more prevalent baseline neurologic abnormalities, more unplanned reoperations, and a low surgical mortality risk assessment. So we have this one study, so now what? I can't recommend any clinical practice changes based on one study at one children's hospital. And so my mentors actually threw this checklist together, and it was published in the European Society of Cardiology. And what this is a recommendation for utilizing machine learning tools and how to use them in the most robust way that we can. And so one of the recommendations in this checklist is to actually explore the use of additional machine learning models. And that's what we did. So we first used that group-based trajectory modeling model, and then we repeated the study using self-organizing maps and k-means clustering. And these are all 3 of them are unsupervised. They both all 3 of them explore longitudinal data, and they find similar patients that have similar characteristics in terms of the phenomenon that you're studying. And in our case, we were studying temperature. So you can see that what you get after you run those models is you can visualize the group assignment and trajectories. So across the board, all 3 of the trajectories looked kind of similar. The k-means clustering, the persistently hypothermic group, those babies started out normothermic and then they dipped down to hypothermia and stayed hypothermic. But in order to really test whether or not these methods are similar, you have to run another statistical test. But what's useful here is that we conducted a kappa test, and that test assesses the level of agreement between 2 categorical variables. And so that would be our group assignment variable. So we found that between the GBTM and the self-organizing group assignment, the agreement of those 2 methods was strong beyond chance. Perfect is 1, and we got a score of 0.92. Now, why do we care about this? Well, this is good because we're showing that there's signal and not just noise in these large data sets. So a final criterion for solution quality that we looked at was using our group assignment as a predictor variable and finding group cluster associations with outcomes. And so what we did is we ran multivariable binary logistic regression models. And here we're showing group-based trajectory modeling and self-organizing maps simply because those 2 methods were almost identical in their grouping assignment. And what we did is we adjusted for all of these variables that you can see in the blue circle. And after all of that, the persistent hypothermia group in both of these models was independently associated with having higher odds of postoperative complications. Hot off the press. So the next thing that you need to do to make sure that your machine learning studies are robust is not only use multiple methods, but replicate your findings at another hospital. So this is just a spaghetti plot. The first step that we need to do is evaluate whether or not we have lots of variability in the data. So this study is going to be conducted to replicate the findings that we already have. And we're doing this in 180 neonates this time. And so what we have here is every squiggly line on the spaghetti plot is a neonate and their average temperature over the first 48 hours after surgery. And we can see that there's lots of variability and there's also lots of hypothermia. So the normothermia line is the red line, and we used a normothermic temperature of 36.5. So this is good for machine learning because we need variability. And in conclusion, if our intent is to change clinical practice or make a paradigm shift, then we must ideally collect lots of data from multiple clinical sites and compare multiple data-driven techniques for corroboration and validation to make our results clinically meaningful. We found so far two very different unsupervised machine learning methods that they share the same patterns, and they found the same patterns in our data, suggesting that there could be a new novel physiologic phenotype and potential risk factor for poor neurodevelopmental outcomes, although this linkage is unexplored. And finally, neonates exhibiting postoperative persistent hypothermia trend are at higher risk of postoperative complications in our single cohort. Thank you.
Thank you, Dr. Hellman, for rounding us out. That was really, really fascinating data. Thank you to all our speakers and for everyone who's been able to stay on. So just a couple quick announcements. Carly, you can see my screen. Let me see. Nope, that's not what I want you to see though. Let me pull it up. Sorry, I'm having a moment. Let's do. Yeah, here we go. Sorry, too many things open. Okay, now you can see the flyer.
Yeah, we got it.
Awesome. Just to round us out. So today's talk had lots of important topics, lots of important but sobering and kind of grim topics. If you're leaving feeling a little bit down, fear not. The rest of our series is going to really dive into how can we mitigate some of these factors? How can we minimize the lack of positive touch? How can we minimize the feeding disruptions? How can we minimize the delirium and all the other amazing things that we've talked about? In April, we'll start off with talking about how can we really work on that positive touch, the holding, the mobility, the skin to skin, the really keeping that mother and infant together as much as we can, protecting that mother-infant dyad. So tune in April, and that'll be our next super exciting talk. And lastly, if you have a second, if you could just scan this QR code, we'll also send it out in the email with the recording. As Gil had said, this is a brand new webinar series. We don't know what we're doing, but we're trying to figure it out. And so we're really excited. And if you guys are liking it, we'd love to do more like this. And you're already registered for all the other webinars. And I think that's about it from my end. Gil, anything else from you, Carly, Sam?
That was what a great collection of talks. I learned something new every time. I really want to thank the speakers. I love when we get through this and have more questions than answers, right? That's how we get better. So great work by everyone.
All right. Thank you all. We will see you next month.
Fantastic. See you guys.
Thank you.
Trying to figure out.
We're down to the last two of us, Shannon. It's just you and me. I think you're muted. Thanks, everybody. We'll see you in about a month.